And of course, we have to do a therapeutic education, which is very important in that case. So we have to inform the patient about his illnesses, about the treatment, to answer all the questions of the patient and his family, and to do at each meeting communication and improve the health education of the patient and his family, and to educate about the disease all the patient and his entourage. So what are the educational messages to improve knowledge about the disease? So the patient and his family, they have to know that pulmonary tuberculosis is a serious disease, but it is curable if they take their medication correctly. It mainly affects the lungs, but they can also affect other organs. The communication is occurring through the air, so we have to encourage avoiding promiscuity and lack of ventilation. And the risk of contamination is very high for the person who is living at the same house with a contagious patient. Pulmonary tuberculosis is often contagious before it is treated, but it is no longer contagious after the second month of treating. So, if the patient, of course, is taking regularly the treatment. So the treatment is given to the patient and he has to take it at home, and hospitalization is reserved for special cases. And for women, we advise them to avoid pregnancy because of the risk of contamination of their fetus. What are the educational messages about prevention, healthy living, and environment? We have to ensure that there is a maximum of ventilation in the house, which will help to reduce confinement. To let know the people that coughing and spitting spread tuberculosis. We have to reduce promiscuity with children, spouses, and all the persons who are living in the same house. The isolation isn't the right way to prevent tuberculosis, but is mainly ventilation, reducing promiscuity, and taking good his treatment. We have to advise the patient to have a good nutrition for his immune system, to stop smoking. He should avoid the pregnancy for the women during this period. And if a woman is taking an oral contraception, she has to change her contraceptive method. What are the educational messages about treatment? The patient have to know that the treatment is free, and also the chest x-ray and the bacteriological examination all is free. They have to take their medication regularly. It is a single dose of all the antibacillary treatment on the same time on an empty stomach 2 hours before meals. And the duration of the treatment must be respected. And the compliance of the treatment during the period are set by the doctor. The patient is regularly monitored. He must come to the health care center for consultation every 1 to 2 weeks, and to the center who will CDTMR he will see a specialist every 2 months. The patient must report his illness and that he is taking antibacillary treatment at each consultation for any other problems, because of the risk of interaction between these treatment and other treatment. So he has to come and to talk to his doctor about any new medication he's taking or any side effect that he noticed. And certain situations must be reported to the doctor, such as a change of job, travel, trips, Ramadan, to know how to solve it. What are the educational messages concerning the family? We have to make sure that the patient's relative report slight symptoms, especially if it is a child and they come to the consultation. We have to make sure to involve the family so the patient come to all these consultations and he taking good his medication. What about the direct supervision of treatment? Previously, in the 19th, the treatment was fully supervised during the first duration of the treatment in the healthcare centers, but that is not anymore the case. We do give the medication and the patient take it at home, and if we have some abandonment of treatment, we relaunch the case in order to prevent resistance, and we have some logistical organization. We do involve family, association, and local authorities. What about treatment monitoring? It is important to monitor and evaluate each patient with TB, regardless of the form of TB. We have a regular appointment that we have to see the patient in to facilitate treatment completion and to allow identification and management of each adverse drug reaction. So, what is surveillance frequency? Whatever the form is. So, how to monitor this? What is the surveillance frequency? Whatever the form of tuberculosis, we have to see, except for patients who are infected by HIV, we have to see the patient once a month during the intensive phase, then every 2 months until the completion of the treatment. What are the modalities of treatment monitoring? First, we have the clinical monitoring. We have to monitor the evolution of signs and symptoms, monitor the patient weights every month. We have to take their weight to know if we have a raise of his weights. We have to ask him about the tolerance of antibacillary drugs on symptoms or if he have some device effects, to assess adherence to the treatment, and to provide and record all the anti-tuberculosis treatment on his guard, the drugs administered, the bacteriological response, and adverse effects. Then we have the bacteriological monitoring that for pulmonary tuberculosis. So each 2 months we have to do a bacteriological examination. So we are talking about conversion if the GenExpert was positive, for example, and it is negative at 2nd month. And if it remain positive, we do it again at the 3rd month and we do GenExpert. For at the 4th month, if it is negative, it's okay, but if it is positive, we are talking about a failure and we have to do the GenExpert. And for the 6th month, if it is negative, it's okay. We are talking about a cured person, but if it is positive, we have a failure and we do GenExpert. So first, for the diagnosis, we do GenExpert or microscopic examination, bacteriological examination. And for the 2nd month, 4th month, and 6th month, we do not do first GenExpert, but we do bacteriological examination first. And if it is positive, we do GenExpert. And third, we are talking about radiological monitoring, the chest X-ray. For pulmonary tuberculosis, we do it at first for the diagnosis and at the end of the treatment, so at the 6th month. And also, if we have some complication, we can do the chest X-ray. What are the treatment results? We are talking about a cured patient. For a patient who is bacteriologically confirmed pulmonary tuberculosis at the start of the treatment and who has completed his treatment as recommended by national policies with evidence of bacteriological response and no evidence of failure. So he was positive for tuberculosis at the start of the treatment and at the end of the treatment he is negative. We are talking about cure. What about treatment completed? It is a patient who has completed his tuberculosis treatment and whose outcome does not meet the definition of cured. For example, for a patient who has pulmonary tuberculosis At first, they have a gene expert who was positive, but at the end of the treatment, they do not have some expectoration. Even if we nebulize them with some physiological treatment, they could not give us a sample of expectoration to do the bacteriological exam. So at this case, we are talking about treatment completed. Also, for the extrapulmonary tuberculosis, someone who had pleural effusion, he was taking his medication, and we do not have anymore the pleural effusion, so we cannot take a sample to know if this gene expert is positive or negative because we do not have that effusion. So we are talking about treatment completed. Failure, we have seen it before. And what about lost to follow-up? It is a patient who started his treatment for tuberculosis and whose treatment has been interrupted for at least 2 consecutive months or more. That a patient who died for any reason during or before starting the treatment. And not assessed is a tuberculosis patient who has begun his treatment, but the outcome is not known. These categories include cases transferred to another treatment unit and those whose results are unknown to the reporting unit. What about prevention? Prevention is very important in the case of tuberculosis. So first we have to screen and treat all patients who are suspected to have tuberculosis disease. And those targeted population are all the patients who consult for respiratory functional signs or general signs who are persistent for more than 2 weeks, and all contact subjects with persons who have pulmonary tuberculosis, subjects with HIV, and all subjects with suspicious chest X-ray done systematically for another reason. So what we have to do for these patients, we have to ask them for these signs, to do a clinical examination, to ask for chest X-ray, and to ask always for a bacteriological examination of the sputum for these patients. For children, we do TST because they could not expectorate. And if the screening is negative, we have to raise awareness among contact subjects to consult at the slightest clinical sign that could appear after this period. Second, we have to screen and treat for also latent tuberculosis infection and not only the tuberculosis disease, because as you see here, tuberculosis is only the small part of the iceberg, but the big part of iceberg that we could not see is the latent tuberculosis. And if we want to eradicate that disease, we have to treat all these patients before they have the disease. So, how to detect those patients? We look for that infection among subjects in contact with confirmed bacteriologically tuberculosis patients. This is any person who has having a repeated and close contact with the index case, and the risk of infection, it depends on the contagiousness of the patient, the period of contagiousness, and the degree of proximity confinement and the duration of that contact. We have to look for that infection among transplant candidates, hemodialysis patients, diabetics, patients living with HIV, persons who are candidated to treatment with anti-TNF-alpha, current and former silica-exposed patients, present populations, and vulnerable or marginalized groups like migrants, refugees, and homeless. As you can see, those are the cases we had talked about risk factors persons for the tuberculosis. So, tuberculosis disease should always be ruled out before talking about the infection. And for people or children who are under 5 years old or HIV patient, we do not necessarily need to confirm that infection. If they have a contact with a person with tuberculosis pulmonary tuberculosis which is bacteriologically positive, we do have to treat them for a latent infection. For the other case, we have to do the TST. But as we know, the TST could be positive if we have a previous PCG vaccination, non-tuberculous mycobacterial infection, if we have an active tuberculosis, and we know that the interferon gamma are more sensitive and specific than the TSTs. So we know that the positivity rate is 5 millimeters. And if a patient have a TST or a NIGRA, it's positive or absence of clinical signs and normal chest X-ray, we are talking about latent tuberculosis infection. And if that TST and IGRA are positive with presence of clinical sign or abnormality at the chest X-ray, we are talking about TB disease. So in Morocco, for patients who have that infection, we give them a treatment, isoniazid, 5 mg per kilograms in adults and 10 mg per kilogram in children for a duration of 6 to 9 months. We could also give them the combination of rifampicin and isoniazid for 3 months. And the effectiveness of this treatment is 16 to 19% of the cases. What about vaccination? So we all know about the PCG, which was discovered by Calmette and Guerin in 1908. It is a virulent strain of bovine bacillus with a certain premonition and a tuberculin allergy. It's a live vaccine with an expiry date. It has to be cold storage, more than 4 degrees, and protected from light. It's freeze-dried vaccine, extended storage. We have to handle it with care. What about the vaccination methods? It's an intradermal route and not subcutaneous. The dose of 0.1 milliliter, very short with a thin needle. Under the tip of the deltoid, we insert only the bevel of the needle into the dermis, and for children less than 1 year, we give just 0.05 milliliters. We have to do it at birth and to repeat it during the first school year. As we can see here, it is an intradermal injection and not a subcutaneous injection. So, when we are giving the vaccine to the children, he will develop at G15 or day 15 or day 25 erythematous induration, hollowed with a small oozing ulceration. We do not have to give him antibiotics or antiseptics, and rarely we can have some incident or accident with a regional adenopathy, dragging ulceration, miliary, or even osteitis, but those incidents are really rare. What about the effectiveness of this BCG? It's had little effects on reducing TB in the community, but the advantage is he allows to have a very low risk for disseminated and severe TB, and the duration of protection is 15 years. The contraindication of this vaccine are all current infectious disease, as all the other vaccines, corticosteroids for a long time or immunosuppressant treatment, and eczema in the woodsing period.